Hello everyone and welcome to our module on ectopic pregnancy. An ectopic pregnancy is a pregnancy that develops outside the endometrium and the uterus. And the most common location for an ectopic pregnancy is in the fallopian tubes. About 80% of ectopic pregnancies occur in the ampulla of the fallopian tubes, which is the mid portion shown here. A smaller number occur in the isthmus, which is the beginning of the fallopian tubes, and an even smaller number occur in the fimbriae, which is the end of the fallopian tubes here. And then beyond the fallopian tubes, there are rare cases where ectopic pregnancies occur in places like the abdomen, in the cervix, or even in the scar from a prior cesarean section. The symptoms of an ectopic pregnancy usually develop in the first trimester, and the two main symptoms are vaginal bleeding and abdominal pain. Now, not all women have vaginal bleeding, and sometimes the vaginal bleeding is very mild, just spotting, so it may go undetected. So in those cases, when women just have abdominal pain, the pain can mimic appendicitis. And so in any female patient in whom you are considering the diagnosis of appendicitis, you also have to consider that one of the possibilities is ectopic pregnancy. Besides bleeding and abdominal pain, women who have ectopic pregnancies have an abnormal rise in the plasma HCG level based on the dates for pregnancy. HCG rises more slowly than what is expected in women who have ectopic pregnancies. Normally, in an intrauterine pregnancy, the HCG level doubles every 72 hours. In women who have ectopic pregnancies, the rise is slower, and anytime the rise is less than 35% in 48 hours, this suggests the diagnosis is ectopic pregnancy. Shown on this slide are some of the major risk factors for ectopic pregnancy. And one of the principles here is that if there's any damage to the fallopian tubes, then the fertilized egg cannot move normally towards the uterus, and it can end up implanting in the fallopian tubes. So for example, a woman who has had a prior ectopic pregnancy can have damage to the fallopian tubes like what's shown on the screen here. There can be scarring, and that increases the risk of ectopic pregnancy. Any cause of tubal obstruction and scarring can lead to ectopic pregnancy. So for example, women who have had a tubal ligation, they rarely get pregnant, but if they do, it's often an ectopic pregnancy. Women who have had tubal surgery, for example, removal of a tumor, can have scarring that leads to ectopic pregnancy. And any woman who's had pelvic inflammatory disease, which I talk about in another video, these women are at increased risk for ectopic pregnancy. Also, women who use intrauterine devices for birth control have a very low risk of pregnancy overall because of the IUD. But if pregnancy does occur, there's a very high risk that it will be ectopic. IUDs are very effective at preventing intrauterine pregnancies, but when a pregnancy does happen, it can occur in the fallopian tubes as an ectopic pregnancy. The diagnosis of an ectopic pregnancy is suspected in a woman who has a positive HCG pregnancy test plus abdominal pain and bleeding. And when these factors are present, the best first test is a transvaginal ultrasound. The classic finding in a woman who has an ectopic pregnancy is an adnexal mass. This is a picture of what an ectopic pregnancy looks like on the screen here. It's not very impressive if you're not used to looking at these images, but this finding in a woman with abdominal pain, bleeding, and a positive HCG is diagnostic of an ectopic pregnancy. The other reason it's important to do a transvaginal ultrasound is because all of these findings can also occur in women who have an intrauterine pregnancy. So by doing the transvaginal ultrasound, you can exclude an intrauterine pregnancy and identify an adnexal mass so you know that it's an ectopic pregnancy. In some cases, the adnexal mass is not easy to identify by ultrasound, and in these cases, if there's no intrauterine pregnancy and the HCG level is over 1500, then there's a very high probability of an ectopic pregnancy. An HCG level this high should lead to a pregnancy in the uterus that you can see. So if you can't see one and the HCG level is this high, the likelihood of ectopic is very high. And lastly, I want to make an important point that transabdominal ultrasound is very unreliable for detecting ectopic pregnancies. It has to be a transvaginal ultrasound for the diagnosis. So like I said on the last slide, sometimes a transvaginal ultrasound cannot definitively identify the adnexal mass of an ectopic pregnancy. In these cases, the transvaginal ultrasound will be non-diagnostic. This can happen if the pregnancy is too small to localize early on, or it can happen if a spontaneous abortion has occurred. In these cases, when you have a woman with a positive pregnancy test, plus abdominal pain and bleeding, but the transvaginal ultrasound is non-diagnostic, what you want to do is follow the HCG levels. Usually they're measured every 48 hours. If the levels are falling, this usually indicates a non-viable pregnancy, meaning a woman who has had a spontaneous abortion. If the levels are slowly rising, however, then this suggests an ectopic pregnancy, and in those cases, after a few days, you can repeat the transvaginal ultrasound, and usually you'll be able to identify the ectopic pregnancy or identify that there's an intrauterine pregnancy that you missed early on with the transvaginal ultrasound. A tubal rupture is the feared complication of ectopic pregnancy. When this happens, there's bleeding from the fallopian tubes, and this can cause life-threatening hemorrhage. A tubal rupture presents as severe abdominal pain, there will be rebound tenderness and guarding, there can be hypotension from hemorrhage, and this is a surgical emergency. There are essentially two ways to treat an ectopic pregnancy. The definitive treatment is with surgery, and this is what's done in patients who are hemodynamically unstable who may have a tubal rupture, and we'll talk more about the indications for surgery in a minute. The second option for treatment of ectopic pregnancy is with medical therapy using methotrexate. This terminates the ectopic pregnancy, and we'll talk about the indications for this in a minute as well, but in general, methotrexate is the treatment of choice in patients who are stable with an early pregnancy. You don't want to subject these patients to surgery if you can use a medication. The two major surgical procedures used for treatment of ectopic pregnancy are a salpingectomy and a salpingotomy. In a salpingectomy, the fallopian tube is removed. In a salpingotomy, there's creation of an opening in the fallopian tube so that the ectopic pregnancy can be removed. One of the major indications for surgery is hemodynamic instability, so any woman with an ectopic pregnancy who has tachycardia and hypotension should have surgical treatment. Surgery is also indicated when the pregnancy is too advanced to respond to methotrexate. So when the HCG level is greater than 5,000, this indicates a pregnancy too advanced to respond to medication. The same is true if you can see fetal cardiac activity by transvaginal ultrasound. Any evidence of tubal rupture is an indication for surgery. This could mean severe abdominal pain or free fluid on ultrasound. And then for women who are unable to tolerate methotrexate therapy, they should have surgery, and we'll talk about some of the reasons why this can happen in a minute. And then lastly, after treatment with methotrexate, women need to follow up for serial HCG monitoring until the HCG level falls to 0. If the patient is thought to be unreliable to follow up, then surgical therapy is often indicated. So the indications for methotrexate to treat ectopic pregnancies are basically the opposite of the surgical indications. The patient has to be hemodynamically stable and the HCG level has to be less than 5,000. There can't be any contraindication to methotrexate, anything like immunodeficiency or hematologic disease or liver or kidney disease. There also cannot be a coexisting intrauterine pregnancy. This is rare, but women can have an ectopic pregnancy and also at the same time have an intrauterine pregnancy. This is called a heterotopic pregnancy, and so when this happens, you can't use methotrexate. And then lastly, the patient has to be able to comply with follow-up. After you administer methotrexate, the HCG and ectopic size will actually increase for the first 4 days, but then they will begin to decrease, and you have to follow the HCG level twice weekly until it goes to 0. If it doesn't fall to 0, the patient may need surgery because methotrexate was unsuccessful. The way methotrexate is administered in women with ectopic pregnancy is as a single intramuscular dose of 50 milligrams per meter squared given on day 1. This is a lower dose compared to when methotrexate is used for chemotherapy, and therefore it has a lower risk of adverse events compared to methotrexate chemotherapy. You may know that when methotrexate is used as chemo, it's often given together with leucovorin to rescue folate metabolism. Leucovorin is not always necessary in women treated for ectopic pregnancy, but it is given in some cases. Serum HCG levels are checked on days 4 and 7, and they should decline until they become undetectable. If there's an inadequate decline in the HCG level, a second dose can be given. And then, as I said before, in some women, when the HCG level does not decline enough, surgery is ultimately required for a methotrexate failure. And that concludes our module on ectopic pregnancy.